Today I am going to discuss about rotator cuff lesion. So basically, in this video, we can learn about what is a rotator cuff lesion, what is the differential diagnosis, what is the type of rotator cuff lesion, and most importantly, the physiotherapy management. Let's start. First is the introduction. We know that the fine adjustment of the humeral head within the glenoid are achieved by the coordinated activity of four interrelated muscles which are arising from scapula and are called the rotator cuff. So the rotator cuff comprise supraspinatus, infraspinatus, subscapularis and teres minor. In the moment of abduction, while we perform a abduction, the supraspinatus sees the head from above and infraspinatus depress the head. The other muscle, the subscapularis, steers the head in front, paralleling the action of infraspinatus muscle. So the combined action allow the deltoid muscle. The combined action of these muscle allow the deltoid muscle to swing up the arm from the steady fulcrum, irrespective of the position of scapula. So, if the rotator cuff lesion occur, which is commonly associated with the supraspinatus tendon, the other cause like a biseptal tendinitis, ECT may give rise a rotator cuff problem, but they are not a common cause. The most common cause is the supraspinatus tendon. What is the incidence of the rotator cuff tear? There is a it is less than 70 year 30%. In patient which are less than 70% or the 30%, the patient which are in between 71 to 80 year are 60%. If the patient are more than 89 year old, then they have 70% of rotator cuff tear incidence. The rotator cuff tear can be further divided into 5 category. Number one is our supraspinatus, and number one category is a type A, supraspinatus and superior subscapular tear. Type B category is a supraspinatus and entire subscapular tear. Type C category, supraspinatus, superior subscapularis and infraspinatus tear. Type D category, the supraspinatus and infraspinatus tear. And type E category, supraspinatus, infraspinatus and teres minor tear. Another classification system is a small tear, which first classification system into four. We divide into four classification system. Number one is class 1 is a small tear less than 1 centimeter. Number 2 a medium tear 1 to 3 centimeter. Large tear is 3 to 5 centimeter, and the massive tear is a greater than 5 centimeter. What are the clinical features? There are a lot of clinical feature. Rotator cuff is common in athletes and sport person. A patient with rotator cuff complain of pain in the shoulder and difficulty in carrying out the shoulder movement, especially abduction. So severe pain at the time of injury, pain at night, pain with overhead activity, passive painful arc sign. Positive painful arc sign, weakness of involved muscle, shoulder stiffness. Individual with the tear of supraspinatus muscle may complain that tenderness over the greater tuberosity, pain located in the anterior shoulder, and the symptom radiating down to the arm. So, what is the differential diagnosis? Differential diagnosis: the rotator cuff must be differentiated from the rotator cuff tendinopathy and from bursitis, like subacromial bursitis. Arthrograph or the ultrasonography can make this distinction. So, additional differential diagnosis to look out for the number one, acromioclavicular injury. Number two, glenoid labral tear or slap lesion or Bencart lesion. Two pathology are present, which one is the SLAP slap lesion and Bencart lesion, labral tear. Next one is the differential diagnosis. There is cervical pathology, cervical nerve root injury, cervical radiculopathy, cervical spondylosis. Next one is the subacromial impingement, osteoarthritis or rheumatoid arthritis, shoulder instability, subscapular nerve entrapment, scapulothoracic bursitis, adhesive capsulitis, bicep tendinitis, calcified tendinitis, shoulder, personalized Turner syndrome, or thoracic outlet syndrome, glenohumeral ligament tear or sprain. What are the diagnostic procedure? Many factors are considered in the diagnosing the rotator cuff tear. Subjective history include mechanism of injury, activity that aggravate or release the pain, and the current limitation to the function and the physical examination finding. Additionally, diagnostic imaging is used to make the diagnosis. Diagnosis is based on number one, history. The therapist should check for yellow flag for shoulder injury. These are passive coping tendency. Number two, depression. Number three, fear, evidence belief. Four, pain syndrome. Five, concurrent pathology, illness, worker compensation, lack of family or community support. So clinical examination, second one is a clinical examination. Active and passive range of motion, strengthening test, and the rotator cuff test can be used. The X-ray used to exclude the sclerosis, the osteophyte formation on the acromion. Number four, the MRI and ultrasound also used. The IMPT, the isokinetic muscle performance test, is used to estimate the functional status of the rotator cuff muscle. And there are a lot of outcome measure score which are used commonly for the assessment and the judgment of the rotator cuff lesion. These are, you can easily pick anyone from here and use in your own clinical setting. So number one is a disabling of the arm, shoulder and hand. Number two is Pennant shoulder score. Number three is global rating for change scale. Number four is constant Morley score. Number five is the rotator cuff quality of life score. Number six is the functional shoulder elevation test. Number seven, shoulder pain and disability index. Number 8 is American shoulder and elbow surgeon score. Number 9 is UCLA shoulder score. Number 10 is the simple shoulder test. Now we proceed on the examination. The diagnosis of the rotator cuff tear can be established by the careful history and structured physical examination. In the physical examination, we should inspect, palpate, and range of motion testing, strength testing, and the special test can be used. So there are tests for the different subscapular, so different rotator cuff muscle. The first one is a test for the subscapularis. There are the four tests: lift off test, in the passive lift off test, belly press, belly off sign, bear hug test. Other test for the supraspinatus and infraspinatus test: external rotation leg sign 0 to 90 degree, jobs test, and the drop arm test. These for the supraspinatus and infraspinatus. And next one is knee test, also for supraspinatus and infraspinatus. Next one test is a test for the trees minor, the Horner Bowler sign. These for the trees minor test. Next are the, there is a, what are the clinical prediction rule for the full thickness rotator cuff lesion. Okay. Number one is a painful arch syndrome. Number two is the drop arm sign and infraspinatus manual muscle test. These are the clinical production rule for the, these are three are the clinical production rule for the full thickness rotator cuff lesion. Next one is the medical management. There are three type of surgical treatment treatment to repair the rotator cuff. Number one is a open repair. A traditional open surgical incision is often required to large or complex tear. Arthroscopic repair in optical scope and small instrument are inserted through the small puncture wound instead of through a large incision. Operation can be carried out under the visual control via video display. So mini operation repair, a new technique and instrument allow the surgeon to perform a complete recovery of the rotator cuff through a small incision generally 4 to 6 centimeter. The operative treatment is done mostly arthroscopically, which is less invasive than the open mini surgery and leave only few small scar. The rehabilitation can start faster, and the patient has less pain during recovery. What are the physiotherapy management in the rotator cuff lesion? There is during the initial stage, resting in a sling. Thermotherapy is used in the form of TENS, ultrasound, SWD, and cryotherapy is habit in initial pain and the stiffness. Exercise, active range of motion to the hand and wrist, forearm, and elbow can be used. During the last stage, the isometric exercise to the deltoid and other shoulder joint muscles can be used. Thermotherapy in the form of ultrasound, SWD, TENS can be help. The mobilization, gradually active and passive mobilization of the shoulder which are as we perform in a frozen shoulder, which are recommended here. The exercise, gravity eliminated abduction, pendulum swing, the flexion and extension exercise, progressive resistive abduction exercise are common. Exercise are some of the effective exercise. These are the progressive resistive abduction are the effective exercises for a last stage of rotator cuff lesion. Once pain is subside, the following measure are advocated: the isometric exercise to the abductor, flexor and extensor of the shoulder joint muscle. Number 2, passive exercise with the patient in a spine position. Relaxed passive mobilization of the shoulder joint is carried out gently for all its movement, especially abduction. Active exercise, these are carried out as follow with the gravity eliminated position. For abduction, here the patient is in spine position. The holding the arm of the patient in a neutral rotation with the elbow flexed. The patient instruct to abduct the shoulder actively. Other hand stabilize the shoulder from above as the patient gradually adduct the shoulder. The lever arm is lengthened by the slowly extending the elbow. This is for abduction. If the patient unable to do, assisted abduction is carried out by the physiotherapist, totally supporting by the weight of arm. This is effective exercises. Next one is a flexion for the patient in a sideline position. The patient is instructed to actively flex the shoulder joint. If he is unable to do, then assisted flexion is carried out by the physiotherapist, stabilizing the shoulder with one hand and supporting the weight of arm with the other. For the rotation, the rotation exercises can be carried out in a sitting position against the gravity. All the above movement are carried out against the gravity, against the resistance. So exercise against the resistance in this final step. All the movement of the shoulder is now carried out against the manual resistance or the resistance offered by with the dumbbells with increasing weight in this last stage. Some open chain exercises and the closed chain exercises can be recommended. These are the sideline external rotation. Lie on a uninvolved side with a small pillow between the uninvolved arm and a body. Keep the elbow of the uninvolved arm bent and fixed to the side. Rise the arm into external rotation, slowly lowering to a starting position and then repeat. This is a sideline external rotation. Then a shoulder extension. Lie on a prone position on a table. Involve the arm in a hanging straight to the floor with thumb pointed toward. Rise the arm straight back toward your hip. Slowly lower your arm and repeat. This is a one horizontal abduction, prone horizontal abduction. This is helpful in rotator cuff lesion. Lie in prone on a table, and this involves the arm is hanging straight to the floor with thumb pointed toward outward, and rise the arm out to the side and parallel to the floor. Slowly lower your arm and repeat. Next one is 90 by 90 external rotation, 90 to 90 degree. Lie in a prone position on a table. A shoulder is abducted 90 degree, arm is supported on a table, the elbow is bent 90 degree. Keep the shoulder and elbow fixed and rotate the arm into external rotation. Slowly lower the starting position and repeat. Next one is a closed chain exercises. Example of closed chain exercises: the therapist apply a rhythmic stabilization and perturbation stresses with the patient shoulder placed on the scapular plane and 90 degree of elevation. This one is a closed chain exercises. Should exercise the following cautions. Number one, sling sport to prevent the excessive stretch on a rotator cuff by prolonged hanging of the arm. Sporting the arm either with the contralateral normal hand or the proper sling is advisable. So, next one is only gravity eliminated position should be adopted by the patient for positioning their shoulder and thereby prevent the excessive stretch on the affected muscle. Preventive measures: what are the preventive measures? These, number one, rotator cuff can be prevented to a great extent by following simple measure. Number one is a proper conditioning of the shoulder girdle muscle by progressive resisted exercises. Number two, avoid a certain sport which constantly cause friction to the shoulder. Number three, avoid sudden jerky movement and abrupt lifting of heavy weight. That's all.